Assalamu alaikum wa rahmatullahi wa barakatuh. Dear organizing committee, dear chairperson, thank you very much for inviting me to be part of this important conference. It should be an honor to be here today with yourself. I'm going to speak today about the management of the refractory ascites, and I'm going to take you through a story of one of my patients. I have nothing to disclose, and I have 65 years old lady. She came to our hospital in October 2019 with bilateral wall lymphedema, abdominal distension, and melena. She was background history of alcohol excess. Upon examination, she was vitally stable. She had moderate ascites and she had some melena with no active hematemesis. Her blood showing the hemoglobin of 10.5 and she had Blatchford score of 8 and she has alcoholic hepatitis DF score of 13. During the hospital administration, she was resuscitated and she gastroscopy that showed grade 3 versus has been banded. Acetic type showing the SAG of 18 with no SPP and no growth in the cultural sensitivity. Urine sodium was 65, ultrasound showing cirrhosis with no hepatic focal lesion. We explained her condition to her. A few days later on, we offered her for alcohol addiction referral, and she was started on the beta blocker salt restriction diuretics and organized for her to have 6 monthly ultrasound with follow-up in the OBD. Ascites is the most common complication in patients with cirrhosis. In 10 years' time, with patients with compensated cirrhosis, 60% of them develop ascites as a consequence of portal hypertension. So it comes to ask the question now, to whom should we offer a diagnostic tab? What should we send and which site to tap? The EASL guidelines recommended for all patients with new onset grade 2 to 3 ascites or hospitalized patients with worsening ascites or all patients with complication of cirrhosis should have acetic tap. And usually we send for 5 bottles. The first one for the cell count with differentiation. Then we send for the albumin and for the total protein cultures and acid phosphorus and for cytology. For most famous 3 sites for the taking the tap could be right or left iliac fossa or suprapubic just 2 inches below the umbilicus. I find that the right iliac fossa is the most safe point, as from the left iliac fossa, you can aspirate some. If there is a splenomegaly, you will cause trauma, and if there is perisplenic venules that will aspirate blood, and so you'll be away from the renal bladder. Usually 20 ml is enough, and coagulopathy is not a contraindication for the diagnostic paracentesis. Once you have that, you should calculate the SAG. If it is more than 11, you will think about cirrhosis, cardiac failure, or nephrotic syndrome. More than 11, you will think, less than 11, you will think about the malignancy, pancreatitis, and tuberculosis. If amylase is high, that indicating the pancreatitis. Complications of the ascites, it is refractory ascites, SPP, hyponatremia, or hepatorenal syndrome. Refractory ascites is defined by the International Ascites Club that is cannot be mobilized despite adherence to the sodium restriction or the early recurrence for which cannot be prevented by medical therapy. And there's 2 major subtypes, either diuretic resistance, so you're reaching the maximum dose with at least 1 week, no response, or diuretic interactable that I will see diuretics that it will induce some complications. So diagnostic criteria is the treatment for at least 1 week, and there is lack of response with less than 0.8 kilogram loss in 4 days, early recurrence after 4 weeks, especially post large volume paracentesis, or complication arise in the form of renal impairment, electrolyte imbalance, hepatic encephalopathy, organomegaly, or muscle cramps. For people who's getting muscle cramps associated with cirrhosis, can be treated with tonic water. They can actually patient get that from supermarkets. If still they have the cramps, then you need to prescribe for them quinine sulfate 200 milligram TDS. With the sodium restriction, the is recommended that no added salt diet to avoid the avoid as well the pre-prepared meals. The most common aldosterone, the diuretic regimen, is the spironolactone and furosemide. First approach, spironolactone 100 for a day, no response in 7 days, you can double the dose. Another week, you can double the dose. No response, you can add furosemide and wait 2 days, no response, double the dose, then double the dose. The other approach, in order to avoid problem with the hypokalemia, you give spironolactone and furosemide together for 4 days. If no response, you double the dose. If no response, you double the dose. The question come now, what is the target for the weight loss? So if the patient has ascites and lower limb edema, so our target should be 1 kilo daily. If there is no lower limb edema, so 500 grams daily, don't go beyond that, otherwise patient might develop complication. So the ASL guidelines for the management of refractory ascites is to go for large volume paracentesis, then reconsider diuretics, then TEPS and liver transplantation. And the large volume paracentesis recommend to be taken for once. I remember that I have some patient that could drain maybe 17 liters a day. So large volume paracentesis shorten the hospital stay and the cost of treatment and the incidence of complication during hospitalization. And you should do it under complete aseptic technique using the pigtail or the Bonanno catheter and remove the catheter in 6 to 8 hours. Otherwise, the patient may develop sepsis, induced infection. And you give abdominal replacement 8 grams for each liter removed. For the first 5 liters, you can give nothing. Ask the patient after the procedure to lie on the opposite side for 2 hours and close monitoring for the vital signs, especially in the first hour. Every 15 minutes, the nurse should check the vital signs. And that can be repeated on weekly or 2 weekly, depending on the requirements. The complication, of course, we can induce infection. It can be peritoneal bleeding, especially if we did it on the left side, and leakage from after finishing the procedure. So avoid that by using that technique. And if that happens, that both for the patient, just stomach bag for a few days, and the paracentesis-induced circulatory dysfunction, you avoid that by giving the patient albumin. Contraindication is spontaneous bacterial peritonitis. It's creatinine more than 3, severe hepatic encephalopathy, hypotension, DIC, or patient with abdominal adhesions. For ASL guidelines, if the urinary sodium more than 30, you can start diuretic cautiously. However, if it is than 30, it's contraindicated to start again diuretics. If the patient has loculated ascites or required very frequent large volume paracentesis, then TEPS should be the procedure. And after TEPS, most of the patients require continued administration of diuretics and salt restriction. Contraindication for the TEPS, including the hepatic encephalopathy, patient with severe liver failure, if there is any active infection or progressive renal failure, or there is cardiopulmonary disease. The other guidelines recommend to stop beta blockers for both refractory ascites and for the Hepatonoma Syndrome, and start midodrine. That would increase urine output and sodium output, urinary sodium and mean arterial pressure, that change the patient from diuretic resistant to diuretic sensitive. The easy recommendation that prognosis for liver transplant for refractory ascites is very poor, and therefore they should consider for the liver transplantation. Back to our patient, she unfortunately missed some appointments in the clinic, and she presented again to the hospital with fever, abdominal pain, and confusion. On examination, she had hepatic encephalopathy with severe ascites. Acidic tap confirmed SPP. Treated with third-generation cephalosporin and started in rifaximin. Patient charged on August 2020 and prescribed diuretics with monitoring the renal function and prophylactic antibiotics and beta blockers. The prevalence of SPP among patients in the clinic, almost 3.5%. For the inpatient, is 10%. If it is in the clinic, usually the patients are asymptomatic. In the hospital, usually they have signs of peritonitis. So it is diagnosed when the acidic fluid neutrophil count more than 250. However, if the acidic count is less than 250 and the patient symptomatic with post culture, then the condition is bacterial ascites. And still, you need to treat both of them with third-generation cephalosporin and give them albumin, 1.5 milligram per kg for the first day, then 1 milligram per kg for the third day. If the patient developed once SPP or has serum acidic, the low acidic protein less than 15, then you should continue on long-term prophylactic antibiotic, norfloxacin or ciprofloxacin. If the patient came into the hospital with acute GI bleeding, you should start him straight away on IV antibiotic to avoid SPP. Over the Christmas, our patient celebrated with her sister and drank alcohol, and presented in January 2021 with 10 Ascites hepatic encephalopathy. The encephalopathy was resolved after a few days, and she received large volume paracentesis for 3 times over the next 3 weeks. Patient experienced chronic hypotension. For that, we stopped the beta blockers, and she developed again SPP after the fourth large volume paracentesis that was followed with deranged liver function. That has been resolved with terlipressin and albumin. So we think about that patient in that situation. Should we think really about tips, the contraindication that she had already current encephalopathy? Or should we think about transplantation? Unfortunately, she didn't meet the criteria. She was drinking alcohol in 3 months. So we started her again on diuretics with urea and electrolyte monitor, and she developed, unfortunately, dry cough. She swallowed COVID positive, and it progressed to renal failure, and she rested in peace in this week. The Hepatonoma Syndrome, they identified by the EASL as recurrence of renal failure of the patient with advanced liver disease in the absence of identifiable cause of the renal failure, with a serum creatinine more than 133. For some, more than 133, we think that's a very low value. However, patients usually are very low body muscles. So 133 is a really high value for them. These two types, type 1 and type 2, type 1 rapidly progressive acute renal failure within 2 weeks and precipitated by hypovolemia, shock, SPP, alkalohepatitis, or nephrotoxics. Type 2 occurs in a patient with refractory ascites and it's steady, increasing slowly. Unfortunately, 30% of patients with SPPD develop HRS. The average survival for type 2 is 3 months. Average survival for patients with Hepatonoma Syndrome type 1 is 1 month. Management just to monitor carefully, especially the vital signs, fluids intake and output, and screen for sepsis. And the cautions with beta blockers, it's recommended to stop them. For paracentesis can be offered if the patient has 10 ascites, unable to breathe just for a few liters, and the diuretics should be stopped. So terlipressin 1 milligram every 4 to 6 hours. It is the best option in that situation. Those can be doubled in 3 days, and you need to continue till the creatinine becomes below 133, and the median response usually around 14 days. You should give albumin 40 grams daily. That will be very helpful. There is some side effects of the terlipressin in the form of the coronary vasospasm. In the American guidelines going with metodrine and metodrine, octreotide, and albumin, or noradrenaline and albumin. If the patient, you think he might got the liver transplantation, then you might offer for him to have a TEPS if the condition is HRS type 2, or hemodialysis if it is hepatorenal type 1. Take-home message: the mortality of 50% within 2 years for the ascites diagnosis, refractory ascites. 50% of the patients, unfortunately, they die within 6 months. The LVP and the TEPS don't improve long-term survival without liver transplantation for most patients. And the liver transplantation should be considered for patients developed refractory ascites. Finally, use the norfloxacin prophylactic antibiotic for SPP and use the albumin prophylaxis for HRS when treating the spontaneous bacterial peritonitis. Thank you very much for attending this session, and I'm happy to answer any questions.